Webinar for February 26, 2025. Today's agenda will be about, our topic will be on Encounter Data Quality Efforts, Part 2. Next slide, please. To introduce myself, I'm Alvin Batista. I will be your webinar moderator for this month. Today's agenda, we will cover 3 topics. First topic will be Encounter Data Improvement Program, also known as EDIP. Second topic will be on Data Quality Reporting Unit, the mailbox communication. And the third will be Quality Measures for Encounter Data, also known as QMED, the new data quality dimensions. The following DHCS staff, we have 2 speakers today. We have Mike Nicholas and Christine Fessler. And your DHCS support staffs, it will be myself, Abby Jeber-Resalasi, Meishan Ng, Xiaoyan Ma, and Felicia Oropeza. For questions and answers, for general questions, please submit your question to the WebEx chat, and please ensure that your questions are visible to all participants because the host is not monitoring private chat. For specific questions, please reach out to the appropriate data mailbox as will be instructed closer to the end of this presentation. Before we move on, we just want to let you know that today's webinar is being recorded for documentation purposes. The link to part 1 of the EDIP series that was done in November of 2024, it will be that link below. It's also on our website. The recorded video, script, and presentation materials will be uploaded to the Data Reporting and Monitoring webinar series. And the glossary and FAQs are also updated regularly every month. So first topic will be on Encounter Data Improvement Program, also known as EDIP. And I'd like to introduce Mike Nicholas, who is the Chief of the Data Quality Improvement Section. So I'll hand it off to Mike.
Good morning, everybody. Next slide, please. I just want to do a kind of a quick recap before we get into the Encounter Data Improvement Project and program in of itself, and kind of recap some of the things we covered in our first presentation about the importance of high quality encounter data. The focus is really on this is to maturely improve the data quality we're receiving from our providers and our managed care plans. This is kind of just a rundown of what we've covered in the past about, making sure that the data is being submitted is complete, accurate, and timely, and that is all following all the national standards and HIPAA reporting requirements. And also to remember that, the good quality data we use is leveraged by the department for multiple business needs. Those are our population health management, which is also now Medi-Cal Connect, our good quality data reporting that we have to share with our federal partners, program integrity through audits and investigations, monitoring outcomes of our members to ensure that they're getting the best medical coverage and services that they get. And also ultimately it's also used to help establish our capitated rates. Next slide. So we're going to kind of focus on the data quality improvement efforts that the department is working on. It's mainly being centered in the data quality branch inside of the Health Information Management Division. There's been a dedicated group that's been internally working on data quality reporting processes and also working on increasing our engagement with our managed care plans to ensure we're having proper oversight, accountability, and providing technical assistance where needed to improve our data quality reporting needs. Today, we're going to focus on the QMED report, which will be handled by Christine later in this presentation, and we're going to be working on discussing the development of a targeted provider encounter data improvement program, which we may be able to work on in the near future. Next slide. So a little high overview of the Encounter Data Improvement Program. This may be a program that we hope to be able to work on in the future. Like I say, there's still hurdles we have to clear, so this may happen. So as a process, we're just giving you an overview of what we hope to be able to do in the future. And that is to help support providers in identifying and remediating encounter data reporting issues, and to improve the overall encounter data submitted to not only the managed care plans, but to DHCS and to our federal partners, CMS. We plan on doing this by hopefully being able to have technical assistance vendors who will support the providers that work in their managed care plans to improve their data quality that they're submitting, to identify issues and to resolve those activities. We plan on doing this through hopefully two types of grants. One is an issue analysis grant, which would be there to help identify and identify root causes and issues of the underlying encounter data issues, and try and develop resolution plans and develop improvements to data quality. That is not around system issues. So these would be really identifying issues with how a claim is being completed. Maybe it could be education and outreach on through vendors to be able to improve how the data is being submitted to the managed care plans. The other part would be issue resolution grants, which would kind of go hand in hand what might have been identified as an analysis grant. But this is like hands-on support by the technical vendors to assist in trying to develop strategies and maybe possibly make improvements to their systems to be able to ensure that the encounter data that's being submitted to the managed care plans and ultimately to the department is of the highest quality. Some of the objectives we're trying to do is to identify providers facing encounter data submission issues and connect them with the appropriate qualified technical vendors to assist in root cause analysis and remediation plans to help resolve their data quality issues. Through this, we hope to promote, a collaborative effort between the department, managed care plans, and providers to help identify and resolving these encounter data issues. This ultimately improves the data that we receive and ultimately helps the managed care plans as well as the department, ensure that our members are receiving the appropriate care. And it also helps, at the end of this, we hope we'll take a look at, how the program went to be able to monitor and share lessons learned, and also figure out how we can improve data quality moving forward. Next slide. So I know we presented this before. This is kind of a high-level workflow of how the program would work. It would be that, we would hope that the managed care plans would help us identify providers and connect them with the technical vendors to be able to identify resolution and identify issue resolution. They would be submitting applications to a third-party administrator who would work with the DHCS and work on approving those grants to be able to establish the work being completed and thus completing that cycle for an issue analysis grant. Next slide. This would be similar for an analysis grant. The same kind of process would take place, except we would have, we would then be looking at the same flow, and at the end, we would be ensuring that the issues identified were resolved and the encounter data issue has been completed, and we're getting much improved data quality from the providers to our managed care plans and then to the department. Next slide. But in order to do this, there are some key participants to make sure this works appropriately. First, below here is a table of what we're going to need. One, we're going to have to be able to identify providers. Those are going to be then matched with qualified technical vendors to help just do the root cause analysis and develop some remediation plans. We're going to need technical vendors who actually have the expertise to work with those providers to help do this analysis and even complete the work to be able to correct any of the data quality issues these providers might be having. The next piece will be the third-party administrator who will be doing the administrative support of this, doing onboarding, screening out technical vendors, and also doing the scoring of the applications and the administration of the program. Then there's the role of the department, which will be doing the oversight and monitoring, including the development of targeted providers, trying to identify focuses on how we would, the types of providers and the types of issues we want to focus on, as well as assisting in the scoring criteria for the technical vendors that would be able to provide assistance, and then monitoring all of this whole program. But this program will not be able to flourish without the assistance of our managed care plans. Next slide. Because the managed care plan is going to play a key role to making sure this program is a success. The department is going to rely on your expertise to help identify those individual providers with persistent encounter data reporting issues. Being able to identify those through the submissions you're receiving now, through denials that you're doing with you are identifying now in the submissions you're receiving. We will also need your assistance to connect those people with the appropriate technical vendors, and then we will also need your assistance with reviewing the draft applications that the providers will be submitting, giving letters of support to signal that you're in agreement with the resolution and the data quality improvements they're trying to make to ensure that it's benefiting both the provider and the managed care plan. Also down the road with initial analysis grants and the resolution plans is to identify that the standard deliverables are there and providing feedback on how those would work and how those would improve to ensuring the success of the providers making improvements. And then finally, at the end, when all these things have been resolved, is giving a confirmation that the issues have been resolved and that the whole remediation has been successful. It benefits everybody because by benefiting this, the managed care will see improved data quality they're receiving from their providers.
Okay.
We'll see reduced possible penalties for encounter data reporting. We'll also see improvement in common encounter data reporting issues and with strategies. And then we can share those because if they come back again, we have already resolution plans on how they can be resolved. And ultimately, it's fostering a better collaboration between the department, the providers, and our managed care plans. Next slide. So in our initial analysis, if we move forward with this program, we've kind of analyzed some of the providers we were hoping to target. And some of those would be our community-based providers, federally qualified health centers, public hospitals, long-term care providers. But those aren't the only providers we're looking to see in this program. We want to prioritize them, but we also want, if there's really providers that need assistance and would benefit this program, we would like to see them identified and applications and support provided by the managed care plan for them. Also, we're also looking to prioritize providers that are in safety net providers that are in rural areas where there's shortages. We want to ensure that we're getting those individuals and those types of providers the benefit of the program to ensure that we're getting the best value out of the program. Next slide.
Hey, get out of my feet, man. I'm gonna feed you guys when I feed you.
And finally, as part of the review, we've kind of identified some high priority data quality issues. These are issues we've looked at internally to try and start identifying where we could focus and get the most benefit from the program if we were to move forward. Some of these we identified have been incomplete and inaccurate encounter data submissions. These could be identified as data elements that are missing or not completely accurate, things that can be resolved through issue analysis grants. We've identified missing national drug codes, NDCs, especially with the finished physician administered drugs. We're noticing a lot of blanks, not appropriate codes in and of itself. The use of invalid NPI numbers. Some of the NPI numbers are not active in the National Provider Database, or we're using organizational providers in a rendering provider field, which is against the standard. We're also having missing and incorrect contract type codes, which impacts the following, which is the missing and billed and paid amounts on the claims. We need this data to help in identifying the services being provided and how much the cost was to help in our capitated rate development. There's also the invalid use of procedure code modifiers, the duplicative encounter identifiers, and finally submissions of encounters for individuals not in the managed care plan for the member. So these are just kind of some of the things that we've looked at initially, and as we move forward, and if the program moves forward, we'll be able to identify other possible data quality issues that we can focus on and resolving. With that, we hope in a future webinar to be able to give an update about the status of the program. This was kind of set to be a high-level overview of what could happen in the future if we have the right approvals to move forward with the program. I want to thank everybody for their time, and if they have any questions, we will try to respond to them the best we can. Thank you very much.
All right, thank you, Mike, for that wonderful presentation. So we'll go on to the next topic, Data Quality Reporting Unit, Mailbox Communication. And I'd like to introduce Ms. Christine Fessler, the Chief of Data Quality Reporting Unit.
Good morning, everyone. I hope you're all having a fantastic Wednesday. So if we could go to next slide, please. All right, so I know that those of the managed care plans that the Data Quality Reporting Unit does respond to, there's a lot of different participants in this webinar right now. So just to clarify, I am speaking to really the managed care plans that are submitting the 274 provider medical files, the PCPA, the 837 and encounter files. So this is specific to those individuals. So we're trying to, through automation and rules, as well as identify some information that plans can send us in their questions to help expedite the process. So over time, we're kind of weaning down the topics that this mailbox handles, just due to the DHCS reorg. So I just would like to highlight specifically the mailbox topics that Data Quality Reporting Unit will help our external stakeholders here. So I have in here kind of the topic, the email subject, and then the specific items in the body of the email that are very helpful for our team to be able to create a ticket, a research ticket more quickly instead of having to go back and forth between the question or the plan that's sending the question. So just specific here, most of the time we get a lot of questions about the files not uploading. It seems like on a monthly basis now, just due to the millions of files that are submitted that the PACES system has to process, that there can form a large queue. So for that, when we do have questions about file upload, missing response files, you see here in the email subject, it is very helpful when you do have those kinds of technical issues that, for instance, the first row here for other technical support, that it is very helpful to include the plan name in the email subject, and then something like missing response file, and then designating what kind of transaction type that is, whether it's 837 institutional, 837 professional, or one of the NCPDP files. And then of course, for the body of the email, it's very helpful to include the name of the file, the data was submitted to DHCS, and then a brief description of the event, such as the file stuck in the submit folder. I do not see the VRF, verification response file, or validation response file. My apologies. And that way, if it's one email that includes that information needed, the staff member, and right now there's 3 who are monitoring the data quality reporting unit mailbox, will be able to more quickly create that PACES data research service now ticket. So just help us help you by providing this information to us. And if we could go to the next slide, please. All right, so just to help level set as well, again, we've got 3 staff who are monitoring the mailbox. We get all kinds of questions. And some of the common email questions we get, plans can really self-help. And so some of those common email questions that we have listed here is like, how do I submit a 274 file? What is a naming convention for a 274 or an 837 file? All of that is in the companion guide. We do get a lot of questions about, I don't have access to the DH Doc Center. You can email data exchange. You know, there's other things about the JSON, the ECMCS, testing phases. Those questions go to EDM data support. We also have an automatic reply on our data quality reporting unit mailbox. We are hoping that is working. And that also has some resources to help guide the plans who are emailing this inbox, such as, you know, if you have a plan data feed question, then we're directing you to the resolution, which for here would be to email that question to planDataFeed@dhcs.ca.gov. All right, so I think we'll move on to the meat and potatoes of this presentation. And again, this is kind of part 2 from our November 2024 webinar on the rollout of QMED 2.0. So again, thank you very much, Alvin, for directing the slides here. Excellent, thank you. So again, a high-level summary. We do include a link here in the presentation. There is an MMCD claims and encounter data site. It does give a very high-level overview of the types of data files and encounter data that relates to managed care plans. So it might be helpful for anybody who's new to Medi-Cal to visit that site for some information there. So again, this is a very broad webinar. There's a lot of different participants here, but this discussion is specific to the medical managed care plans that are currently receiving a QMED report card. And QMED stands for Quality Measures for Encounter Data. It was rolled out in 2015 and hasn't really been updated since then. So obviously there's been quite a few changes in contracts, requirements, and new programs to report on for the reasons for DHCS to update the QMED. So DHCS will be doing this in a phased approach. We are currently in phase 1 of QMED 2.0. And again, this is targeted for the managed care plans currently receiving a report card. For phase QMED, we are looking to expand the scope to incorporate other plan types such as the SCAN, the PACE organizations, managed care dental, and then eventually behavioral health. Just due to the purpose of data quality reports, the QMED 2.0 will be updated on a regular basis. And when I say updated, that means, you know, whether or not certain data quality measures need to be retired because the quality has improved so much that scoring it, everybody passes, which would be wonderful. We hope that eventually occurs for all of our measures. But then we'll be adding and removing measures over time as well. And all of that will be communicated well in advance. So, and then just to briefly say, you know, in the coming months, we're still in phase 1. We will continue our internal and external stakeholder engagement to prepare for the QMED 2.0 implementation. So more details on this in the next slides. All right, so again, this is just to highlight when we're discussing encounter data in the context of DHCS and what does that mean for quality measures, is that, you know, most of the time when staff is in conversations with our external trading partners, sometimes they will refer to them as claims and we refer to them as encounters. What we mean when we say encounters as these are the post-adjudicated encounters that the managed care plans to submit to DHCS. So this is after the managed care plans have already done all the processing on their side of when providers send those claims to the managed care plans. And then the managed care plans accept or deny those encounters. And then after all of that, the managed care plans will submit those post-adjudicated encounters to DHCS. So again, for the purposes of the phase 1 QMed, this does not include fee-for-service claims. We can go ahead and go to the next slide. So this is trying to provide, not sure if it's that much easier, and I did create the slide, so if it's still confusing, please let me know. But this again is just trying to highlight the roles in the participants. So again, we've got the providers and who are providing services to members. And so depending on the contract type that providers have with the managed care plans, they send their claim to the managed care plan. And the managed care plan, based on their system, they will accept or reject that encounter, right? So the encounters that DHCS PACES receive are those post-adjudicated. And so with the PACES system, we will, based on the edits of that system, it will reject or accept a file, or it will accept or deny encounters. And those are all the information for the errors and companion guides are available in the DHCS Doc Center. And those are very crucial to look at all of that information to get a better understanding of what the error codes mean, what type of VRF the plan is receiving. And so just please remember to look at those resources available to you. So let's go ahead and go to the next slide. All right, so again, this is just kind of a bit more detail of the phased approach to QMed 2.0. Again, we are targeting, there's about 23 managed care plans that are receiving a quarterly QMed report card. Phase 2, again, we'll be looking at to incorporate initially the PACE organizations, SCAN, the managed care dental plans, and then probably a phase 3 for the county behavioral health plans. So what we're really hoping is for QMed to apply to all healthcare delivery systems so that we can have a holistic and consistent approach to identifying and measuring quality data submitted to DHCS. Right, so if we could please go to the next slide. So this is just an overview of the background of QMed 2.0. Again, it was the last recent update was done in April 2024 to carve out pharmacy as being incorporated in the scoring for QMed. So right now there are various data quality measures or data quality dimensions to which the measures in QMed report card are scoring, which is based on completeness, accuracy, reasonability, and timeliness. For QMed 2.0, we will be actually adding additional data quality dimensions. So unfortunately, the CART will have to come up with another way to kind of, mix the words around because I personally like CART. It's easy to remember. But if we could go to the next slide, please. All right, so for phase 1, as part of the stakeholder engagement that we did do, I believe it was prior to November 2024, we did a survey of the managed care plans who are currently receiving the QMed report cards. And the responses there were consistent with kind of internal views at DHCS, which is the scoring for the current QMed report card is quite complex. Especially when you're looking at the scores over time and how they relate to impacting your current score. So we're looking to simplify the scoring methodology. Again, as I mentioned from the prior slide, we are going to incorporate uniqueness and consistency as new data quality dimensions. And then we're also going to be looking at a more rules-based approach to ensuring the encounter data is submitted to DHCS meets the definition of fit for use across our various programs that we have. For phase 2, we will be adding new data quality measures to reflect the state CalAIM and federal reporting requirements. And again, as mentioned before, we're looking to expand the other delivery systems for QMed reports. We could go to the next slide, please. All right, so these are some of the data quality measures of focus. So some of these might be recognizable for the plans receiving report cards, which is we have timeliness, we have measures for encounter data volume, and then things like duplicate encounters. So one of the measures that we are going to highlight today is an existing measure in QMed, the current QMed report card. However, we are editing it to make it a more accurate measure of the denied encounters that can actually be corrected. So what's highlighted here is the denied encounters turnaround time, and this is specific to contract language in the managed care plan boilerplate contract, which is denied encounters need to be corrected and resubmitted within 15 days of denial. So if we can go to the next slide, please. So this just lays out the current QMed 1.1 measure. The measure is quite complex. It's looking at a horizon time of what percentage of denied encounters are corrected within 15 days, 30 days, and 60 days from the date of denial, which again is from the date the plan receives a response file from PACES. So it's a pretty straightforward numerator. The denominator is the count of denied encounters. Now, the issue with that, and really would like to highlight the staff that have been working hard on this, Stephen Lefebvre and Prasanna in the data quality branch, is that there are certain denied encounters that cannot be corrected, and that has to do with the PACES system. So what we're doing in QMed 1.1 is in the denominator there, we are removing the denied encounters that cannot be corrected. And again, this is all specified in the error addendum within DHCS Doc Center. And please let us know if you need access to the Doc Center. So what we're doing there is with this measure, we're actually looking at the denied encounters that are correctable that should be corrected within 15 days. So this is one of the ways that we are trying to improve the accuracy of the measures themselves for QMed 2.0. Okay, so we can go ahead and go to the next slide, please. So as part of our stakeholder engagement, we would really like to start to get a better understanding of some of the challenges that managed care plans are facing in order to comply with some of the QMed measures. Specifically, we're looking at timeliness measures and some of the topics listed here. So I am going to turn this over to one of my counterparts, Stephen Lefebvre, and he is going to walk through some of these plan questions, and we would love to get responses over the coming month to some of these questions. So if I'll turn it over to you, Stephen, and thank you so much.
Thank you, Christine. So Christine and I were talking about QMed. We're doing a lot of brainstorming and we're working on finalizing QMed. And part of that was discussing thresholds. And while we were discussing We've done a lot of work on QMed, starting with researching QMed 1, then brainstorming with everybody what would be some new measures, and really our focus is really data quality, database management, and integrity, and contract language, that kind of thing. So I said, we really haven't heard from the plans yet. I've been involved in many projects in my time, and I always try to talk to the downstream user who's going to be actually utilizing this. And so I thought, well, I think we need to talk to the plans. We've sent out surveys before, back when we were the Encounter Data Quality Unit, and I thought, well, and Christine suggested that, well, we have an upcoming webinar. This is literally like 2 days ago. We have an upcoming webinar. Why don't we just post the questions then? So instead of having a Q&A and saying, send us questions, we're going to kind of turn it around and we're going to ask you some questions because we really want your feedback. This is going to be completely voluntary, but we want to know what challenges that you might have. Christine has laid out some of the measures and, some reasons why we're looking at those metrics. And but we want to know, what are your challenges to achieving good QMed scores in these measures? So some of those are submitting duplicate encounters. Those of you who have been around in the DHCS encounter data world for a long time might remember the EDQU, Encounter Data Quality Unit webinars. And I used to present a piece for maybe, I don't know, 8 quarters. I did a piece on duplicate encounters. And the reason for that is duplicate encounters has been invariably the #1 error that we've received in encounter data since inception, since the beginning, over 10 years since the beginning of encounter data. And we just can't seem to get it with you all. So we actually made it a measure in QMed 2.0. So what are your challenges with duplicate encounters? I know I've worked with plans on trying to mitigate this, and there's been plans that have asked, well, what is PACE's duplicate logic like? So we have worked with them to provide them that, and I actually had a plan build into their system for inbound encounters, a edit, very similar, mirrors PACE's edit, in order to screen duplicate encounters when they receive their encounters from providers and from subdelegate plans, contracted plans. And so they screen those. I dealt with another plan that said, well, we want to screen our outbound encounters to you so that we can make sure that we've never submitted that encounter before. And we really invite that and we encourage that. And anybody who wants to participate in something like that, contact your encounter data specialist and we can help you. But what are your challenges with submitting duplicate encounters? Submitting duplicate encounter service lines. This is something that I've been advocating for years for, and we are putting this into the QMed. We're going to be scoring based on duplicate service lines. So duplicate encounters and duplicate service lines, we have millions upon millions of duplicates. It's the #1 error, and a lot of them aren't corrected. And duplicate service lines, a lot of them aren't corrected. They're not voided, they're not replaced. So now we're going to be adding this to our QMed measures. What are your challenges with submitting duplicate service lines? We want to know what they are. What are your barriers? How could we help you with this? Also, we have submitting all post-adjudicated encounters to PACES within 90 days of the date of service. And that is in QMed 1, that's lag time. We want to know, what are your challenges with receiving that? I know I've heard some plans say, well, this is an issue we have with providers. They're not submitting timely encounters to us. So when we're late with an encounter, it's because we just received it. And a lot of this, Mike Nicholas was talking about this kind of issue of working with providers to improve their encounter data, and part of that could be the lag time frame. How can we help? We have done outreach to plans, and outreach to providers might be the answer. Let's talk about it. Send us those questions related to that, or answer our questions. What are your challenges? Correcting denied encounters. The next two are related. I'm going to read them both. Correcting denied encounters, resubmitting denied encounters, those with error messages within 15 days from the date of denial. That would be turnaround time. That's a QMed 1 measure. The last one is a contract requirement. That is in the contract. But then why are we including corrected denied encounters? Because they're not all corrected within 15 days. And if they're not corrected within 15 days, we have millions upon millions that are just never corrected. So that's a database integrity issue. So the last one is contract. The one before is database integrity. And, frankly, we don't want these in our database. We want them corrected. It doesn't help us. It doesn't help anyone when our database is cluttered. So these are both going to be part of the QMed 2.0 measures. What are your challenges with that? Why have these encounters not been corrected? Not just the timeliness of the turnaround, but also the ones that were never corrected. Why? What can we do to help? As Christine said, we're making the measure more accurate, the turnaround, we're going to be subtracting out encounters that cannot be corrected. For example, denied replacements or denied voids, they can't be fixed. They're dead-end encounters. So we've always given a percentage on that QMed measure of turnaround time. So to account for those, well, we're going to be extracting those out from the denominators so that we will have an accurate count and we'll know exactly how many uncorrected encounters there are. And we don't necessarily we're trying to tailor this and work with the plans to help you succeed. We're not just looking to fail you and scrutinize you. We're doing this as a way to get a good view of how each plan is doing, so we can work with that plan and focus on how to help that plan improve. So this really is an improvement effort. That's on candidate equality. So those last two, let us know. What are your barriers? What are your challenges? So this is completely voluntary. Again, we really would like you to participate. Even if it's just addressing one of these or all of them, I'm sure I've worked with a lot of people for many years, a lot of the same people in the plans. You are a pretty stable group. You must love your jobs. So, because you stay there, and it's been a pleasure working with you. Now let's work together to figure out how we can do this, how we can improve our encounter data quality and achieve good QMed scores. So with that, I want to thank you. And I'm going to popcorn back to Alvin over here. And thank you for your time. And thank you, Christine, for setting it up.
All right. Thank you, Christine and Stephen, for that wonderful presentation, and also Mike for the earlier slides as well. So on to the next slide on communication. So here we have a listing of all of the data group mailboxes that are available for you guys to use. We have 274 medical provider encounter, 274 behavioral health plans, 274 dental, BH short doyle, PACE, DHCS documentation center requests, technical questions, especially with ECM, CS, CCM, and JSON, and MCDSS webinar support. So those are the email links to those. And if you're, just a reminder, if the message is urgent, please mark urgent in the subject line or in the message box. On to the next slide for resources. So for behavioral health managed care, here's all the resources, emails, and the topics that should be covered with those resource emails for behavioral health managed care. Next slide. For dental managed care, those are the resource emails and the topics that should be covered for those emails requests. For programs for all-inclusive care for the elderly, also known as PACE organizations, these are the resource emails and the topics that should be associated with those emails. For medical managed care program, here's all the resource emails and the topics for those emails. And technical support, as you know, these are the resource emails and the topics that should be subject to those email resources. And before I go on to the next slide, just want to go over some of the questions that are in the chat. Just make sure that they are all been answered. So starting with Lauren Clark, Maddie from LA Care, are local codes not a high priority encounter data quality issue? Looks like that we may have to get back to you on that.
Oh, yes,
Yes.
local local codes. Yes, that is
Oh, thank you, Christine.
definitely a high priority. I believe so an APL went out an all plan letter. I want to say back in 2015 or so that notified managed care plans the need to submit encounters with the national codes. So some of the challenges that we have heard from our managed care plans is that providers are submitting encounters to managed care plans using local codes. So, you know, from a DHCS perspective, we cannot. Our contract is with the managed care plans, and so the survey questions that Stephen presented, obviously some of those also relate to the local code issue. So how can DHCS help managed care plans, you know, in providing extra resources or, you know, sending the providers to look at the X12 transactions, but really it's kind of up to the managed care plans to make sure that the providers are using the appropriate national codes. So, you know, in the coming months, I am hoping to work with Stephen to have a webinar that kind of walks through some of the documentation on the DHCS Doc Center, and maybe point to some additional codes questions that do come up. But yes, this is a very big priority. If some of our other staff are on here, Jeff Jennings, he and I have had many discussions about the codes, but yes, very big priority. So more to come on that.
Thank you, Christine. And also piggyback off of Debbie's response as well. So yes, the local codes are high priority as well, and they are being addressed. Okay, so on to next question from John. Updated 274 provider data companion guide has not been updated yet in the documentation center. File samples emailed are not opening correctly. Does anybody have any comments on that?
Yeah, so I think we might need a bit more information on that. I believe so the 274 companion guides, and I want to apologize. An email communication that went out, I believe it was last Friday, that was leveraging Power Automate. So to help kind of communicate and any changes to the documentation center, the team had set up automated communications that whenever a file is posted to the Doc Center, it would send an email to the data quality 274 contacts. So I think what happened there was that maybe a file had been posted and removed, but either way, there was a follow-up communication last Friday that related to the behavioral health 274 companion guide and VRF, and that was to notify the medical and 274 behavioral health and then dental plans as well that the VRF or the response file schema is updated to include some higher level counts. And please refer to the email that was sent out Friday afternoon to those types of changes. So there's going to be a testing phase within DHCS PACES to test the usage of a VRF that's beginning March 1st, and then April 1st would be the rollout for production. So if you're having any additional questions on that, I can discuss internally with some of the other individuals regarding the Doc Center companion guide, but maybe if you could provide a bit more information on what specific companion guide, if it's the behavioral health, the 274 medical, or the 274 dental, that would be very helpful for us to get you a response to that.
Thank you, Christine. And also picking back off that as well. Yeah, we have so many different 274 provider data as well. So if you also differentiate, like Christine said, whether it's managed care, behavioral health, dental, etc., it would definitely help out. Jeff Jennings, you got your hand raised. So
Yeah, I apologize. I had to join our session this month late, and when I came in, I heard Christine explaining about that email that went out last week about the companion guides. As Christine was saying, that's automation. Our mistake. Apologies. In terms of what's going on with the various 274 file companion guides, whether it's behavioral health, medical, or dental, you can contact the data exchange mailbox if you have questions about release dates, and we'll let you know about that. But for now, there is no new companion guide that has been posted. So just so you know, there's a pending one from behavioral health, but I don't think that's been published yet. Otherwise, as Christine mentioned, this was about the response file that's issued after processing a 274 file and the additional information that's going to be in that response file. So just wanted to add on and kind of repeat what Christine just said and to emphasize it.
All right, thank you for that response. Got a question from Daniel Mason. What are some examples of uniqueness and consistency? And Christine already responded to that as well regarding uniqueness and as what's defined in the section 3.8 of the companion guide. Got a question from Eugenia. Will eligibility related denied encounters be considered as not correctable? It looks like Serge Zelenoff responded that it depends on the reason for the denial. And a question from Norm Decker. Rules for duplicate service lines need to be reviewed, particularly around DME, I assume is durable medical equipment supplies. There are DME CPT codes that represent different products, so the CPT can be listed twice, but represent two different products. Do we have a subject matter expert that can elaborate on that? Well, it looks like go ahead.
Well, I think we'll need a bit more information on that, but I will say, so thank you very much, Serge. He's definitely our SME. Oh, and Mike has popped on, but I would say that it sounds like a modifier question. And again, the companion guide specifies the restricted list of modifiers that are allowed to denote a service that wouldn't be flagged as a duplicate. But Mike, since you have your video on, I'll go ahead and popcorn over to you if you have some further clarification.
Yeah, and I think it really goes back to the details around that code in and of itself and understanding what it is. Because again, yes, there could be descriptions around that code. So if we could get some more details, we might be able to help better formulate a response.
Thank you, guys. We have a question from Kim Gowdy over at Centene. We love to go to within 90 days of a paid adjudication date, not DOS, or I assume it's data service, or only measure original submissions, not replacements. Don't include voids adjustments in the timeliness measure. Does any of our subject matter experts have any comment on that question? Hearing none, looks like we may have to get back to you on that one. Ken Phillips from CCAH. Plans are required to append modifiers to encounters versus providers, submitting them and distinguishing between duplicates. This is time consuming for MCPs to review each encounter to make distinction. Looks like these are all comments when Stephen came on board and asking the plans some of the issues that they are arising. So looks like we may have to get back to you on that one. Another
Sorry
one.
about that.
Right.
Well, you know, on some of these, we have to go discuss if it's a policy thing and formulate a good response, and also just take input from our trading partners into consideration, so that if we need to change any of the agreements or policies that we can do that. So,
And we take all these into consideration.
yeah.
We also will probably run these QMed measures in different variable solutions using past data to determine success levels with plans. So we're not just doing this willy-nilly. We're actually looking at real data that's already been submitted and looking at how successful plans would be if we set such and such a threshold or that threshold or whatever. So these are good suggestions or good questions, and we will address them.
And then another one from Kim Phillips. We pay Medi-Cal rates to our providers, and plans are penalized when submitting corrected claims late due to retro rate adjustments. Let's see here. Another one from Kim. Oh, Kim's asking about
Actually, I wanted to say that is a fantastic question. That's the kind of stuff that we really want to hear about. What are barriers that are completely out of your control? So that is the kind of stuff that we're looking for. Keep them coming.
Yes. Kim is asking, it's been a while since we received our QMed report. Can we get a status on that? Or when the next one's coming out?
Yes. So I will say we have been working internally to help streamline the internal review process we have for sending out the QMed reports. And so we're just waiting for our data release team. We're going through some extra documentation, so then that way we can expedite when the QMed report cards can be sent out to plans. We do apologize that it's a bit later than normal. The QMed report cards were available much earlier this month. However, it's the internal review process for the data de-identification and just ensuring that we have some data release forms set up so that going forward, we will be able to turn those around much faster. So I would say hopefully before the end of February, we'll be able to send those out to plans. So we are working on it. We really want to share those. So thank you very much. We're glad you're looking at them and looking forward to receiving them. So thank you.
All right. We have a question from Edwin Gonzalez over at CHD. Does DHCS expect encounters to be resubmitted if additional payments were made for those encounters as part of the 2024 TRI requirement? If resubmission is required, how will this affect QMed timeliness calculation for the plan?
Ooh, these are some questions we're going to have to definitely, sorry, spend some time collecting and responding to. We want to be thoughtful in our communications. And then for when we do in this webinar, we would love to receive any follow-on questions probably over the next month regarding some of the challenges that Stephen mentioned. Please send those questions to Data Quality Reporting Unit at dhcs.ca.gov. And in the subject, it would be helpful, the subject line of the email, like the February 2025 encounter, questions.
And also, I would like to add that, Edwin, that's a fantastic question. And these are the kinds of questions we want because we need to look at this and determine. Also, if anyone's sending questions of this nature, can you kind of let us know the scale of this? How many of these do you actually get? Because it could be that if you get a lot of them, it might affect your QMID score. We have to research this. But if it's a small amount, then it may not so much. So we'd like to know volumes too. How often is this happening? How much of this do you see? So please include that when you send us your questions or your challenges.
And we see a question from Laura Clark Meddy or LA Care. So will local codes be removed from the Medi-Cal fee schedule? It looks like Debbie responded back that local codes pertain more directly to fee for service versus encounters, but they're being addressed. And then also two, fees are for codes are part of the local code resolution. Of course, stay tuned for more details. Kim Phillips, we have our providers bill according to Medi-Cal guidelines, aka fee-for-service rules. We have one from Wasim Kadada. Oh, Jeff, you got this one. I made multiple requests to get access to the documentation center, but I have not heard back or been
Yeah.
granted. Looks like you responded. You're going to check
Yeah.
on that. So cool. Thanks.
Oh, great. And you just sent the email. Thank you so much.
Yep.
We'll follow up on it. Apologies. If I may, I just want to say one thing about the Doc Center. It's a pretty good thing, but it's not perfect. And occasionally we have some issues with links, et cetera, et cetera. Bear with us. We're always trying to be better at that and improve wherever possible. But yeah, just so you know, sometimes we'll accidentally send you a link that for some reason doesn't resolve, in which case let us know and we'll either get you the doc or give you a link that does work. So thanks.
Thank you, Jeff.
everyone,
Appreciate that.
for your patience with that. It's Microsoft. It's pretty good. Just not 100%.
Yeah, piggyback off you too, Jeff. Yeah, I got a new laptop, so I'm still learning the functionalities on that too. So still learning. All right, Zinglu, will DHCS publish an encounter data provider manual to address billing scenarios where Medi-Cal fee-for-service billing manual applies and does not apply to encounter data?
Well, as Zing Liu has pointed out, this is not something that we have right now. This is a good idea. We can take a look at this. Right now, we're really focused on QMed, finalizing QMed. So I will keep this on in the back of my mind and bring it up, and we'll discuss if this is even possible. Thank you.
Yeah, thanks, Stephen. I mean, what we do want to say about that, we've known this for a while, that there's been some overlap between managed care encounters and fee-for-service billing, and they're two different things. I know we're running a little late here, so I don't want to get into all the detail, but at this point, we know to target that issue and how to best figure out the differences and when and where they do intersect, if at all. But as part of the larger encounter data improvement program, proper billing for encounters is one of the things we'll be targeting.
And then final question from Jackie Liu. Does DHCS consider waiving the timeliness measure in Q4 2024 QMed due to the submission of encounters for TRI requirements?
We will definitely take that under consideration.
Well, wonderful discussion, everyone. I know we went a little bit over, but just want to go over a couple more slides real quick before I let you guys go. Next webinar preview for March 2025, we will focus on behavioral health plans 274 data submission. There's the meeting information. So the next webinar will be on March 26th from 10 a.m. to 11 a.m. And once again, wonderful discussion, wonderful time of the month. Thank you guys for your time and effort and staying with us this whole time. Once again, if you have any questions or comments about the webinar, if you like what you see, if you like me hosting, any comments, please submit it to the DHCS mailbox and we'll definitely reach out to you guys. So once again, thank you guys. We'll see you again next month. Enjoy your day. Yeah.